All right. So the charge I was given was to talk about rural minority health. And what I want to do is I want to unpack that a little bit for you. I'm going to do that, I promise. But what I want to leave you with is a couple of thoughts. So there are disparities that exist in our country based on race and ethnicity. And there are disparities that exist based on geography, based on where you live. And when you overlay those two, we have a dual disparity, and that's where you will find many of the greatest disparities we have in our country. So said another way, there are disparities that exist between African Americans who live in urban or non-rural areas and rural areas. Rural African Americans tend to do worse than non-rural African Americans. Rural whites tend to do worse than non-rural whites. Rural Hispanics tend to do worse than non-rural Hispanics. So as you unpack this, as you think about this, thinking about what is it about geography, what is it that is unique about geography that seems to impact across populations. And I think that may provide some direction for you as you think about these issues. So what I want to do is I want to start off kind of at a high level with the data, and I'm going to hit you with a lot of data, and then I'm going to get a little bit more granular. So this is a study that was done by researchers at HRSA, and what they show is that there is this growing gap between metro and non-metro, or rural and non-rural populations in terms of life expectancy. And what's interesting about this is that the latest data that we see is that we've actually just experienced the first decline in life expectancy in this nation since 1993, and that's very notable. So in 1993, there were a lot of young men who were dying from HIV. That caused life expectancy to drop. Today, it's being tied to three conditions, which are, as a group, are being referred to as diseases of despair, and these are opioid overdose, alcoholic cirrhosis of the liver, and suicide. And there's research that is emerging that is showing that these conditions are disproportionately affecting rural populations. There's also research that's showing that it is growing beyond the rural communities and growing beyond largely white communities. It's actually starting to have a disproportionate impact in communities of color as well. But it's being driven by these three things primarily. So again, as you focus on where you need to think about where we can have an impact, I think this helps provide some of these clues. So of course, a lot of this goes back to social determinants of health. And this is a framework for the social determinants that comes out of Healthy People 2020. And I'm going to just focus in on a couple. Across most of these social determinants, rural residents do not fare as well. But in terms of poverty, rural residents tend to make $10,000 less per year than non-rural residents. About 5% more children live in poverty in rural communities than non-rural communities. Educational attainment is lower in our rural communities. It really cuts across the board. What I want to do, though, is I am a very visual person, so it kind of helps me to think about this in terms of pictures. So this is a map of what are referred to as persistent poverty counties in the United States. To be defined as a persistent poverty county, your county has to have a greater than 20% rate of poverty since the 1980 census. So these are counties where there is poverty for 40 years. This does not mean that there are not a lot of other communities in our country that are facing poverty. Other communities go in and out. So don't think that this is the only place that poverty lives, but this is where poverty is persistent by definition. And you see the dark blue is rural and the light blue is urban. So most of these are rural communities. What is interesting about this is I bet most of you could name most of the regions that pop out from this map, right? You've got Appalachia, you've got the Delta, you've got the Southern Stroke Belt, you've got the US-Mexico border. So I'm going to show you a few other maps, and I want you to watch this. So this other work comes from the University of South Carolina Rural Research Center. They have a focus on rural minority health. So this is a map of where African Americans live in rural America, okay? So going back to this again, take another look. This is where rural Hispanics live in America. And one more time, this is where rural Native Americans live in the United States. These are the same maps, and it's not by accident. So one more map, just because I find this fascinating. These are the health profession shortage areas in our country. Again, same map. I will also tell you that if you map almost any health condition, you'll get the same map. So poverty, I think, is probably the greatest predictor of health status that we have. And this, to me, is one of the underlying factors that really bridges across populations in terms of how we look at this. So again, when we talk about rural minority health, it is rural health, it is minority health, it is poverty. All of these things interplay to affect the health of our populations. So what I want to do as part of this also is to hit you with a little bit more data. This is from work that we have done through our Rural Health Research Center, and we did a rural mortality study. First, we had done an update to CDC's 2001 Rural Health Chart Book so that we were able to look at a 10-year update, see how the country is faring based on geography in terms of overall health status. And I'll provide you with the links to these reports. But then we followed that up with a rural mortality study. And for this study, we pooled the mortality data for the 10 leading causes of death. We did this by HHS region, and then we also looked at data for the Appalachian region and the Delta region separately. And we looked at it by age and gender and cause of death. We did not look at it by race and ethnicity, although I think we probably could have and maybe should have. I think that this may be another study that probably would help to inform research in this area. But what I've done, these are the 10 HHS regions, and again, we pooled the data by HHS region. So what I've done is I have created, or I've shown the mortality indexes for the HHS regions that overlap with those maps that I show you. So I'm going to show you for HHS region 4, which overlaps with a lot of where African Americans live in the United States. I'm going to show you for region 6, which overlaps where rural Hispanics live in the United States. And I'm going to show you for region 8, which overlaps with where a lot of rural Native Americans live. And you'll see the disparities. Now, to be clear, this is not data that is unique to the minority populations. It's all rural populations in those regions, but I think it still helps to show a picture of what's happening in these regions of the country. So again, this is that map of where African Americans live in the rural United States. I'm going to show you the data for region 4. I could have also shown you the data for the Delta region because we did a separate analysis for the Delta and Appalachian regions. But I wanted to go down into the South in particular. And this is what the mortality index looks like. So for every one of the 10 leading causes of death, we have the national average at 100. And we've separated this out. We've analyzed it by geography using RUCA codes. So this is a scale of rurality, and the red dots are your most rural, your more remote rural communities, and the orange dots are the next level of rurality, which essentially is your small town rural residents. And you see that for almost every condition, rural communities fare worse than non-rural communities. And this is for men age 25 to 64. We have this for other age groups as well. We have it for men and women. I'm going to show you the female chart as well. But essentially the way you read this, so for example, for lower respiratory disease, if you are a rural man in the deep south, you have a greater than, you are more than twice as likely to die from lower respiratory disease than other men in the United States. Unintentional injury, you're 60% more likely to die from unintentional injury. I will note that I talked about diseases of despair at the beginning. That the diseases of despair fall within these categories. They're not unpacked from these categories. So when you look at unintentional injury, about half of the rate of unintentional injury is accountable by motor vehicle injury. About 26% is a rate of poisoning by overdose. So that's within this. Similarly, liver disease includes other liver diseases beyond cirrhosis of the liver, alcoholic cirrhosis, but it falls within that category. And then this is the chart for women in the same region. Again, lower respiratory disease, you're more than 2.2 times as likely to die from lower respiratory disease. You're twice as likely to die from unintentional injury. Really across the board, 60% greater chance of dying from diabetes. Looking at where rural Hispanics live, so taking you down to region 6. You see, again, lower respiratory disease. This is one that emerges almost everywhere in rural communities. Smoking is a major cause of lower respiratory disease. We know that smoking rates are considerably higher in our rural communities, about double in our rural communities among youth in particular. 80% chance, 80% greater likelihood of dying from lower respiratory disease. Again, unintentional injury is one that emerges frequently, 60% greater chance of dying from unintentional injury. I'm going to keep hitting you with these. You can have these. Please refer to them throughout your deliberations. And I'm also going to show you where you can access these on your own through our website, because this is a tool that you can manipulate. You can create your own charts and maps based on this data. It's actually a wonderful resource. I think, I'm a little biased, of course, but I think it's a great resource because you can actually customize it for the message that you want to convey for your region, for your areas. And then this is, again, for women in Region 6. Again, much, much higher rates. Heart disease, 80% greater chance of dying. Lower respiratory, again, comes up as twice as likely. And then the last one is Native Americans. So I focused in on the upper Midwest, the Plains states. There are, of course, a lot of Native American populations down in the Southwest as well, but that data then starts to overlap with the US-Mexico border. But we see these differences. Suicide is 80% greater. I don't want to overstate these data because this is not Native Americans independent of other rural populations. And we know that Native American populations are relatively small populations, so the relative impact that they have in influencing the data for the whole region, I think, is something we do need to do some separate analysis. But I will tell you that other data indicates that suicide is a huge, huge problem within the Native American community. So in some ways, this helps to affirm that. Similarly, we know that alcoholism is a major problem within the Native American community. And in fact, in this region, we see that alcoholic liver disease, or liver diseases in general, are 60% greater likelihood of cause of death. And similarly, you see the same thing in women, only worse. Liver disease, 2.5 times as likely. Unintentional injury, about 50% greater. So I'm going to take you back to this map now, because there's one region of the country that we have not talked about, which is Appalachia. And I've done a lot of work in the Appalachian region, and I think it is a notable region because it is the region of the country where we still see the greatest disparities among Caucasian populations. So looking at this, and I put this in here because this is what has really gotten a lot of popular press, a lot of media attention lately, and you've probably seen some of these articles, really focusing in on these diseases of despair. Washington Post has done a whole series on this. A lot of other media outlets have picked this up. Some in ways that are helpful, some in ways that I think are a little bit less helpful. There was an article in the Wall Street Journal maybe 2 weeks ago that said that rural America is the new inner city. That's probably not the way to message this. But again, it helps to highlight some of the challenges that are going on in rural communities. So the data for Appalachia, and I've highlighted again these areas where we see the diseases of despair, but again, you see the same trend. What's interesting is Appalachia looks a lot like the other regions that I show you. You have unintentional injury, about a 60% greater likelihood, suicide, about a 40% greater likelihood, but you also have lower respiratory disease, more than twice as likely. And similarly with women, you see very similar trends. One that is interesting that emerges in some regions of the country, which I will point out to you because I find it fascinating and alarming, is that when you look at homicide rates, homicide is one that tends to be the exception to the rule, where urban homicide rates tend to be higher than rural. But when you look at many rural regions of the country, you'll see a disparity between men and women, where homicide rates among men are much, much lower, but homicide rates among women are much, much higher. Appalachia is one of those regions. You see here that women in Appalachia have a 40% greater likelihood of dying from homicide, but if I go back, you see that men are at the national average. So again, this I think would point to domestic violence, something again to pay attention to as you look at this data. So the other thing I want to highlight, and this is a study that we are just getting started on. It's one that I'm very excited about. It's work we're doing for the Appalachian Regional Commission. We are unpacking this data a little bit to get specifically at the diseases of despair, so removing the overdose deaths from injury, removing the alcoholic liver disease from liver diseases. And this is the first cut. This is for the entire Appalachian region. That includes 420 counties across 13 states, coming down here all the way to Alabama and Mississippi, from the southern tier of New York. And what we find is when we pool the data across diseases of despair, it's a 27% greater likelihood of dying from a disease of despair if you live in Appalachia than if you live in the rest of the country. And the way this breaks down, it's a 7% greater likelihood for alcoholic liver disease, a 17% greater likelihood for suicide, and a 40% greater likelihood for overdose death, for opioid overdose. We are currently working to analyze this within Appalachian subregions and by economic distress levels within Appalachia. And what I guarantee you will see is that as you get more granular, we will identify the hot spots within Appalachia. They will be more in that central part of the region, which has more economic distress. And we will see these differences really highlighted to an even greater extent. So having hit you with a lot of data, what I want to do is I want to end on a more positive note and talk about some of the resources. So the first is one that Tom had referred to. This is work that we're doing for his office. We are developing a series of evidence-based toolkits, and this is a very methodological process, a very intentional process of looking at what works in rural communities, what is the evidence base telling us, what are the models that appear to be promising, and trying to capture those in this toolkit in a way that we can help communities replicate those models and evaluate those models. Part of the intention is to create a rural evidence base. As Tom noted, most programs are not tested in rural communities. We don't know what works in rural communities, and I don't think it's a safe assumption that urban models can be scaled down. Rural is not a smaller version of urban. It may be that there are unique models that we need to employ in our rural communities, and much of that work, I think, is probably already being done. We just don't know necessarily where to shine the light to know what's happening in different parts of the country. That's really the intent of this project. We start by looking at the programs that are funded through Tom's office to find those models that appear to work, but we also cast the net wider, and we capture this in what is known as the Community Health Gateway. This lives in the Rural Health Information Hub. The Rural Health Information Hub, their website, I always have to advertise the hub, is ruralhealthinfo.org. It is a one-stop shop for everything rural. The folks up in North Dakota do a phenomenal job, and they have for years with this. Within that site, you will find the Gateway, which is our home to these evidence-based toolkits. This is an old screen capture. We do 3 or 4 different toolkits a year. Since this has been done, we have additional toolkits on substance abuse, oral health, a number of different topic areas, and I think we're up to 13 toolkits now. Another body of work I want to let you know, and we are actively engaged in this work as well. This is work that we're doing for the Robert Wood Johnson Foundation, and this is to really take an intentional, positive focus on rural health. So the focus of this work is really threefold. It is to identify assets and strategies that work in rural communities, to identify partners and sectors that can be engaged to employ those strategies, and to develop a set of recommendations on how we can bring that together so that all of the partners can effectively influence outcomes in rural America. As part of that, and this is probably overwhelming, it's a little overwhelming to us too. As part of that, we've tried to systematically capture assets, and we've done this through the literature, but we've also done this through a number of forums that we have convened at both the national level as well as different rural regions around the country. And it's just, again, it's a framework to help us think about what are the assets that can be engaged, that can be leveraged in our rural communities, and how can those be employed to create change across our rural communities. And we use this framework from McKnight and Kretzmann because, it just helps provide a framework for this. But essentially, we're looking at assets at the individual level. What are the strengths of the people? We're looking at organizational assets, which are local assets that are controlled locally. We're looking at community assets, which are local assets that are controlled outside of the locality. So you can think of a branch of a bank that has either a national or a regional bank with a local branch. So that branch may be an asset, but it's not necessarily controlled locally. And then we wrap this in the culture and history of the region. And that's something that I think is also really important as we go into different regions of the country. And we just completed 4 of these regional visits over the last month, and we went to the Delta, we went down to the U.S.-Mexico border region, and I can tell you, it is no surprise, I'm sure, that history and culture is different, but it's also probably one of the greatest assets that we have. People are proud of their heritage, they're proud of their communities, and that's something I think we can very much leverage on behalf of the communities that we serve. And then finally, I promised you I would give you the resources. So this is where you can find both our update to the chart book that I mentioned. This was an update to CDC's 2001 data report. It's about this thick when you print it out, so don't hit print. But it is a wonderful resource. Again, I'm biased, but it's a wonderful resource to get all of the data on all of the health conditions and to actually compare that data back to the 2001 report to see how things have changed. And then this is the physical report, but you can go to either ruralhealthinfo.org, which I mentioned, or the Walsh Center website at NORC, and you can link into the tool which you can manipulate this data, create charts and maps that are relevant to the region that you serve. And I think that's all I have.